Joining for this talk on healthcare. A broad setting of context. I think today's talk predominantly will focus on building software products for providers. Providers meaning physicians, doctors, nurses, labs, hospitals, clinics. Because the domain of healthcare itself is so vast, I mean, you can hardly even touch it in 45 minutes. So I wanted to kind of focus on the area that I know best. So with that context, I think I would like to start. I think asking you if you guys can see my screen.
Yes, we can.
Yes, we can.
Okay, perfect. So let's start with with a big shout out to our heroes out there who are fighting this world war, as Amit highlighted. Their efforts have always been praiseworthy, but I think this is the time when we more broadly notice it, and it becomes more evident. While we are trying to be as safe as we can and isolate ourselves, those are the ones who are walking into fire and dealing with it. So a big shout out and thank you for everyone who's out there on the front line trying to deal with this. So let's talk about healthcare. And I think a lot of you people would have seen something like this, which is essentially an actual snapshot of a prescription that's written by a physician. Now, this data point is from US, with I think 7,000 odd patients were affected because of scribbling done by physicians when they write prescriptions. This is still, I think the number is much larger here in India. The only issue is there's not efficient tracking for us to really know what the numbers look like. But the case is not very different. So when these kind of challenges were posed to software developers back then, I think they followed a very simple approach of solving this problem, which was look at the best practices of building software. And when software were being built in 70s and 80s, I think the only examples and best practices that existed were of building ERPs, basically backend solutions. And these ERPs were built with a single focus in mind, which is automate the entire workflow. And the objective is that anything and everything that the user does is being done in the ERP, and that becomes their tool of preference. That's their primary job. And blue screens, green screens. I'm sure you've seen all of that. Basically, highly data intensive and highly complex interfaces with a lot of focus on data entry. And that's how the systems evolved. And I think the same best practices and guidelines were used to build software products for healthcare workers also. Now, the core difference between ERPs and the softwares that get built for providers is, the primary function of a provider is not to do a back office function. They're not like back office in charges or officers who need to just live in here. Their primary function is to examine the patient, make sure the patient is comfortable, give the right treatment to the patient. The second objective is there a way of effectively documenting the treatment of care in a technology so that one, it helps to accurately reflect the condition of the patient, and two, depending upon which country you're talking about, it is evident that you need that to be able to get paid for that visit if it's been covered by insurance. But what has ended up happening, when people just picked up these trends and started converting the forms that physicians used to scribble into digital technology, is scenarios like this. A lot of you people who work in US healthcare, or those people who've been to hospitals in India where they actually use an EMR could relate with this. Where I think because of the way these systems are built, a good portion of a physician's time today is is I won't call it invested, is actually spent on the technology itself and not on the patient. And it's a big problem wherever EMR technologies have been adopted very broadly. EMR stands for electronic medical records, where physicians are actually disinterested to a great extent to continue to operate in this field because of the challenges that come to surface for having to use the technology, which is not really built for this. This is, having set the broad context, what are the things that you need to really look for, when you want to build products for healthcare consumers, whether it is patients or whether it's providers. The very first thing that you need to understand is while in any other domain, the damage could be financial. And of course, some domains like, airline industry, where maybe if you put a bug into the airline system, it may crash the plane, which is equivalent to what I'm going to highlight, which is anything and everything that you do has a potential to kill a patient. If a particular drug is being ordered and because of the way it's built or the way you display the information to the end user, the way they process the information that are presented to them, all of that has a potential to essentially kill a patient if it goes wrong. And I let that think it, because this is the key thing that you all should remember and have at the back of your minds when when you're working in this field. The second biggest thing that comes to the front is compliance is key. This space is super highly regulated, whether in India or outside India too. And there are multiple regulations that one needs to take care of to have a product that's kind of certified for use by healthcare professionals. Some of those guidelines, for example, CCPA, this is a law in California where any and every data, not just healthcare, it applies more broadly, any and every data of a user, they can essentially ask you as a software provider or a vendor to delete their data. You need to kind of delete all of that. And CCPA evolved from GDPR from Europe, which is again about privacy rights of the data. HIPAA is predominantly used in US, but it is part of India's guidelines for software products too. Again, this is around privacy. High trust is how do you get environment, your infrastructure certified, servers and connectivity and security, so that the technology is safe for healthcare use. In US again, there's meaningful use criteria where beyond the non-functional requirements, meaningful use was the first time where actually functional requirements were laid out as to what a software EMR or a software product needs to support for physicians, so that it could be certified as it supports meaningful use technology. There are workflows that are meaningful for end users, and then whoever does that, for some time we're getting money from the government. Coming to Indian market specifically, the kind of compliances and regulations that exist in India, I mean, it's a laundry list of acts. We'll share the deck for you to go to. But what this highlights is, after the fact that, you know that whatever you do can kill a patient, the second most thing that you will deal with and work with in this domain is compliance and regulation. The third objective, which I was highlighting when I was trying to highlight the differences between ERPs and how the software products for caregivers should be, the objectives are very different. So you need to design and build a system with the objective that these end users have to spend the least amount of time on your technology, but still be able to get their workflows done and have as much time they can have to deal with the duties of providing care to the patients. And as simple as it may sound, this is very important and something that is difficult to enforce. When most people build their products so that its use is maximized, in healthcare we should build these products to make sure the use is minimized. but the workflows are still completed, which means the entire use should be efficient. The next thing that you need to remember is this domain is complex. I've been in this domain for about 15 to 16 years. Have always been healthcare in 16 years. So it's not like I've been in projects on and off in healthcare. Starting 2004, I've been in healthcare. And I would say I would probably know just 5, 10, maybe, if you stretch it, 15% of there it is to know. And I'm still talking about this software products, and I'm still not talking about hardware equipment that goes into healthcare and all of that. Just the software aspect, the domain aspects. So this domain is complex, and it is super complex. Every specialty you'll deal with, it will give you a new flavor. Every physician you meet, even if of the same specialty, will give you a different flavor of how he or she prefers to treat the patient versus the other. So it is complex. It it can get overwhelming. So have that at the back of your minds, that though it is complex, there are ways to work with that complexity. And what is the way to work with the complexity? Iteration is the key. Whether it is with respect to you picking up the domain and learning about it, or whether it is about building a product in healthcare for providers. The workflows are complex. There are tons of things that providers do and use which have to be supported by a product. And if you wait for building all of that, then you'd probably be waiting for a good number of years introduce your product to the market. And I think all of you know that's the worst thing that a product a product owner or a product manager can do, which is keep their product inside for years. So the key is being able to iterate, and I'll share some ideas around how that iteration should be made possible. The next most important thing is when you want to build products for healthcare, you need to identify the research group that you will work with. And when I say research group, it's essentially your end user. You have to create a community of your end users or potential end users. And within that community, you need to segment them based on your focused areas and the areas of interest of providers. And what I mean by that is, not every provider or every doctor is interested in, using a solution that is backed by artificial intelligence. But that does not mean there is no doctor who doesn't want to do that. So you need to identify those early adopters and create your focus groups within the research group that you create, such that these align with the thought process and the interest areas of those doctors also. You'll find some doctors who are super interested about telemedicine, and the others are not. So just make sure that your focus groups are very focused, and the interest areas of these end users are also taken into account. Now, what happens if you don't do that? I think the biggest thing that will happen is you'll get a lot of noise when you try to do your research on product use cases and product announcements. Okay. Sorry, that was my daughter. So the biggest thing that will happen if you do not get your research group right is the research will yield a lot of noise, and you will be basing your decisions of product investments based on data that's inaccurate. And it will lead to having wasted product cycles in building something that's not really useful. It won't get adopted. It won't get used. So you'll get all those kinds of things. So as attractive as it seems that you have a research group and you should just give it to everybody and get everybody's views, it actually doesn't work that way. And the last point is something that's kind of table stakes for any product development. Make sure that your product investment, whatever feature, enhancement, small or big, that you're planning to work on is actually backed by data. You have data to back it. If you are someone who's dealing with an existing product and want to enhance it, look at the data that's available from the existing product to inform your decisions and to be able to quantify the kind of impact that you can make. so that then allows you to set realistic goals for yourself and then measure your performance or the enhancement of your performance against those goals. So you can, as a product manager and product owner, you can very objectively define what success would mean for any of the features or enhancements that you'll roll out. If you are someone who's starting a new product and you do not have data from any of your existing products, the key is to then create a research group and do what we call as confidence test, which I'll talk about in a minute, to inform the backlog of your products. So any important questions that you want to ask before I move to my next slide?
Would really appreciate if you can, put some light on the data compliance part, in terms of the GDPR, and health data is a very, crucial aspect. So how do you ensure that you are on the right side of the law?
See, the only way to ensure that you're on the right side of the law, for example, if you're talking about Europe, is to comply with the laws that are listed in GDPR. What it talks about more broadly is how the data is collected. Do the people who are giving you this data clearly know what is going to happen with this data, and the fact that you're collecting this amount of information, how it will be stored, whether it will be encrypted or not, how is it transferred to the infrastructure where you're storing this, is the infrastructure itself encrypted, and who will you share this data more broadly with? Are there any third parties that you're going to share this data with? And very specific to CCP and GDPR, it also now gives you a provision where you can ask them to remove your data. But the fact is, when you have regulations, you also have ways to kind of skip those regulations. So under CCPA, if this data is protected health information, then you can't delete it, because again, it is important for an audit trail perspective that, okay, I treated this patient, what I did with them. You can't just delete that data. So the idea is, one, transparency. Your end users need to know what you're collecting and why you're collecting it, how it's being stored. From an infrastructure perspective, the data needs to be encrypted during transit and at rest. And all the third parties that are going to be dealing with your data or are going to help you in delivering the services that you're offering to your end customers have to contractually be obligated to provide the same level of security and compliance. Now, there are specific countries that have laws about the health data being, should be residing within the boundaries of the country. India also does that now. Singapore is another example. US is another example where they mandate as part of HIPAA and other local laws that all the health data of their citizens has to reside within the boundaries of the country. So these acts and these regulations that I've highlighted very clearly lay out the kind of security that is required. For example, if you look at high trust, it to the last level of detail in a very granular manner highlights the kind of security that is required on your infrastructure, the security aspects that are required on your web application or on your mobile application. And then they'll validate it and give you a stamp of certification for high trust, which then gives a level of comfort to the providers who are buying your solutions or contracting with you short term or long term to use those services. Now, for startups, it could be a challenge, but this is something that you have to balance out. Maybe as a startup, you may not go for high trust on day one because it is a costly affair. But in those cases, as from your contracts as a startup perspective, you very clearly highlight the kind of compliances that you have in place, whether it's CCPA or high trust, and you indicate that this is a proof of concept or a pilot or a alpha or a beta, and these are the exclusions from a security perspective, so that the transparency aspect is clarified and the end users or the hospitals or clinics who are buying your solution can essentially take an informed call and informed risk about trying this. In many of those cases, they're okay with doing that because the exposure of a pilot or an alpha and beta is very limited. And they also understand that, early companies go through these phases and eventually they do get certified. So, moreover, you do get your alphas and betas working with these plans. But they will look for what kind of other provisions that you have in terms of, how do you maintain security, have access to data, what third parties do you use. All of that happens in any case, whether you're a big company selling products to big hospitals or you're a startup trying to sell it to a small clinic or a chain of hospitals.
Okay, thanks.
Now, moving on to trying to highlight some of the aspects that I was talking about. When I say iteration is the key, how do you really iterate? I'm sure a lot of you people have heard the term minimum viable products, and you've heard multiple versions of that word. More recently, I heard something called as BVP, which is barely viable product. But what I'm indicating is you heard some version of MVP. You've heard some version of what a product market fit would look like. But what nobody highlights is how do you get to the product market fit? If you believe that your product market fit is going to take 6 months, 1 year, or 2 years, you can't just keep the product inside for that long. So how do you really iterate to make sure that you are out in the market early, testing your product, you get it out there early to get the right feedback, and then you continue to add value. Plus, when you go out there and put it in the market, let users use it in small numbers or whatever numbers that are required from your alpha beta size perspective, then it is something that is adding meaningful value to the end user also. You're not giving him a fractured experience. And this is a classic example, that one of my design colleagues who works with me highlights, which is when you're talking about iterations, you're really talking about going from a hoverboard to a bicycle, not going from 2 wheels to a body frame to a handle and then eventually a cycle. There's a huge difference between these two. But before I get there, let's start from the idea stage. Now, when you have ideas, these ideas, whether you will have these ideas or your company will have these ideas, there is a process to get these ideas validated. One, as any regular product development that you would do, you need to identify who your user community is. What are those businesses that are going to buy your solution? Who is your buyer? Who's your end user? And then you do a set of site visits, workshop, and interviews with these people to understand and inform, what your backlog is going to look like and what does a product market fit look like. Now, once you've done that and you have enough data there, you start to prototype things. A lot of people at this stage start building the product, and then they'll start a process where they can start showing the WIP product to customers. That, I think, is a lot of investment without getting enough detail about what the end users would really like to see. And I'm sure many of you have faced this in your domains too, but this is true for healthcare too. When you are trying to build something that is next generation, you go people and ask them about those things. See, what they are telling you is aspirational stuff. Not that all of that will be true too. What I have personally also noticed is, when you get a lot of these aspirational stuff from end users and you think this is the next big thing you build and you release it, you hardly have a lot of adoption, because this, what they've shared with you is their aspirational stuff. But when it comes to day-to-day bread and butter, the core workflow is what they have to spend most of their time. So a lot of these interviews, workshop, and site visit output needs to be qualified by prototyping, by looking at what is the amount of investment that the Scrum teams, the engineering teams have to put into it. What extent of value would the customer derive out of this? And then that will start informing more broadly whether you have a product market fit or not. So we also, even in our today's product development and Athena, with our group, we do this process, what we call as test, look at the confidence of each of these prototypes, build those prototypes, send it to our research group, send it to our engineering teams, see what is, what are those low-hanging opportunities and fruits which can be built faster, and the users are indicating that there is a lot of value in it, and then use that to then prioritize and inform your backlog with respect to what you should build first and what should be built next. Now, once you've decided the priority of your backlog, then comes the, how do you decide on how to build it? Do you build it like, okay, I've built one wheel, now I'm going to build the second wheel, then I'll build the frame, then I'll build the seat, and I'll build a handle. It'll take, whatever good amount of time that it's going to take. Do you have the option and the opportunity to wait till then, or you would rather build something fast that's useful to end users, if not for 10 transactions, at least for one transaction, and then evolve it from that. So what the slicing mechanism focuses on is on the latter part, which is, if your product market fit talks about supporting 10 features, start with the first feature, build, and when I say feature, what I mean is build it as a hoverboard. Don't build it like a wheel. And what that means is, if you look at in this image, the hoverboard, the scooter and the cycle all have a single objective. Anyone who's using these has a single objective, and that objective is to go from point A to point B. What differs is the experience, and that experience is what you need to evolve. Because when you're trying to build a bicycle directly based on interviews, workshop, and site visits, you don't really know if the version of bicycle that you'll get is the version that people want. So you start small with pick up those same one or two highest priority transactions or workflows, build them like a hoverboard, which is, it still works. It gets you from point A to point B, but the experience is different. And then keep evolving on that experience to get to the bicycle stage. Any questions on this philosophy and concept?
So Mohan, one question around building the MVP and giving the value. So there are obviously in today's world plethora of products in choose any domain, right?
Yeah.
You will have so many competition, and you need to have a differentiator to pull the customer from the other end to your side.
Right.
How do you in this case there can be plenty of hoverboard companies, and they are already offering this. How do you create that differentiator as a first version itself, or you're suggesting that you basically reach out to only subset of people, and that's the art basically we need to choose? So how do you go about that?
So the difference is, at what level of market readiness are you entering the market? For example, and this has been proven time and again. Pick whatever domain you want to pick. There was always been competitors who are more broader and full-fledgedly available in the market. Take most recent classic example of Zoom. Before Zoom came into play, Cisco's WebEx and GoToMeetings were market leaders. Now, looking at the adoption of Cisco's WebEx and GoToMeetings, someone like Zoom should have launched in the market after 4 or 5 years, right? If that's the only concept that you look at.
Right.
So the difference is the concept of the focus group that I was talking to you about. When you and this is broader theory, and that is, when you look at your end user community more broadly, there's always a percentage of that community who are early adopters, who are ready to give it a try, who are ready to go beyond what they do on a day-to-day basis and try something new out, even if it's something that's evolving. Those are the people who we call as early adopters, and that's the focus group that I was talking about. Identify your focus group community based on what you really want to do, and then whether it aligns with their level of interest or not, their areas of interest or not. Because day one, you can't go and compete with the giants in the market. So identify your focus group, make sure your priorities and their area of interest are aligned, and then you start working with them. That gives you an opportunity of having an audience that is interested and thinks about doing and achieving the same things that you do. So that's the key. Otherwise, that you'll classically be building a bicycle without knowing that this is exactly what an end user was going to look for, and then now you've already built the bicycle, you have the wheels, and you have everything. Now it's very difficult to go and change that experience. Maybe if you're a startup, you already burnt your money. There's no more left to pivot from there. So that's where this early process to check, to market, to test always helps. The key is, to find the group of users who are interested in doing what you're trying to do. That doesn't mean really develop AI. You are focused on developing AI workflows within healthcare. You need to find, end users who are keen about AI. Where do you find them? There are so many healthcare forums based on focus groups where you can start interacting and engaging with these users. There are so many forums where physicians already meet today, whether within a hospital or more broadly geographically also in different events that are organized by different specialties. You need to get a slot there to go and speak about your product and then identify what your focus groups are going.
That makes sense. Thank you.
Mohan, would really appreciate, if at the end of the session you can share the list of those forums or go-to resources, because as a startups or the guys who are building the new products, it's the key is to reach out to those identified set of users for beta and limited availability.
Yeah. See, one more key thing, because you bring up this question about startups, which I'd like to let you know, is one is you reach out to users more organically, okay, via these meetups and stuff. The other inorganic way of doing that is there are a lot of CIO events also that happen in a lot of states and even in the country level. And at these CIO events, it's like any other event where they take some money and give you a booth and you can talk about your product. A lot of hospitals now in India are also trying to engage with startups, where they will either sign up with a startup that seems interesting to give their technology a try in exchange of maybe hardly paying anything, or maybe just paying a fraction of what the cost would be. And many of them are also trying out options of taking equity in those companies for becoming the alpha beta sites for them. So that's also a great option that you can try out. What I'll do is after the meeting ends, I'll draft a list of all these different avenues that you can explore across CIOs or CMIOs and end users directly, and reach out to them for creating the focus group that we really want.
Thanks, Mohan. That would be really helpful for all of us.
Any other questions before I move to my next slide?
Mohan.
So Mohan, Abhishek here. Yeah. So this is a good framework, but then what you mentioned is ideas, prototype, and then slice and confidence backlog. If I take this back to regular products like an e-commerce product of, let's say, building a specific product, let's say soap, the interviews, the workshops, and the time is spent into the idea generation or the user research at that specific level would be pretty less as compared to healthcare related products, right? I mean, I need to be not less than 100% sure that this is something that I'm building. Probably, if I start prototyping it, if I start showcasing it to my customers or my early adopters, I need to have that confidence level that I have done my user research right. So when you compare this to uh, a commodity kind of a product as compared to healthcare, where do you see the time spent in terms of idea generation and user research, how that differs in both these examples?
See, based on what I've seen in healthcare till date, I think the amount of time that's spent on research in healthcare is very less as compared to the amount of time that's spent by commodity companies like cream makers or soap makers. And the reason I say that is because when you try to build those products, there's a huge research element that goes into also identifying and isolating the chemicals and molecules that you would like to work with. What is also true is in many cases they just build on top of an existing product that they already have, make some minor modifications and launch a new brand. I think in those cases it's much lesser. The market research side is much larger. But more broadly, from my experience, the end user research in healthcare is not as vast and is not as extensive as is done for the other market or other products that are out there. And that is one big reason why a lot of solutions that we have in the market are so different, and they struggle for adoption. Even if you look at the Indian market and the kind of startups that have come into the Indian market, you will notice their core typically, those one or two use cases, and that is what it gets used more predominantly. The other 90% that they build, assuming that these are the things that physicians like, because maybe in the rest of the world, this is exactly what physicians do.
Thank you so
Examples of practice. Yeah.
Mohan, in the interest of time, we have 10 minutes. For questions, please type your questions in the chat box, and we'll have detailed question and answer session later. Thank you so much. Over to you, Mohan.
So, after having highlighted the ways in which ideally you should look for building products in healthcare, I mean it is true for other domains too, but predominantly software. Maybe if you're talking about commodities and hardware devices, things might be different. Let's look at some of the unsolved problems that are in healthcare, or problems that have not been solved well in case of healthcare. Now, I'm sure a lot of you people have visited physicians. What you don't see is there's no comprehensive documentation of your visits. Now, if you really go to bare bones, is it really needed? In situations like today, maybe not. All you need is probably, even a paper tag, color-coded paper tag would do that. Okay, this patient is COVID-19 suspect, this patient is COVID-19 positive, and this patient is COVID-19 recovered. Because these are those testing times where I think everybody is just surviving on bare minimum essentials. But when you go beyond that, for all the other healthcare needs, you actually need a comprehensive documentation of, as a patient too, and providers also need it, so that we don't live in times today where if you go back to the physician in 6 months, he still remembers you and your medical history had used to happen maybe 20, 30 years back. In current times, if you go to the same physician after 2-3 days, he won't recollect having met you or having given you anything. So the context is important. What is important is what meds are you taking? Why are you taking those meds? Someone gave you steroids. Why did that person give you steroids so that the other person also doesn't give you steroids? Because these ignorances can result in life-threatening diseases. So, for a classic case is in a case of getting diabetes because of multiple doses of steroids. So, as lightly as we may take, it is super critical to have a record of what treatment was given to the patient, and what prescription was given, what tests were done. There are many tests which should not be repeated in a particular time frame. But there's no way for anyone to know unless you specifically tell them, and that too if you are aware. If you don't tell them, you potentially get life-threatening tests done multiple times. So it is crucial. Now even if you look at broadly in India, there's no solution that really allows you to do comprehensive documentation of patient care. In US, there are solutions, but they're not the best, which has resulted in a high degree of physician burnout. You need these documentation because unless you submit these documents, you don't get paid for your visits, because most of the outpatient visits are covered by insurance. So that's one. What we do not have today is a Book My Show for patients. Now, why do I refer Book My Show? It's because Book My Show addresses the gap in the market of the variety of the end user. End user's choices basically. See, as someone who would like to go to a mall and a movie theater and watch a movie, while that is the primary objective, the choices are different. You'll go to the mall and the theater which has the movie that you like. So you won't use a PVR app to book tickets, or you won't use a big cinema one to book a ticket. Why? Because your needs are not specific to big cinema or PVR. As an end user, your needs are broader. So why does Book My Show fit the bill so well? Because it addresses the diverse needs. That I know that my users need to watch a movie and they can watch it anywhere that they like. What healthcare is, you can map that example directly on healthcare patients. As a patient, your healthcare needs are also diverse. For a simple cold and cough, you'll probably go to the MD physician next door to get treated. If it's getting a little complex, you're not really getting treated, you'll go to the one that you prefer to go to in the hospital. And then if it's still not getting treated, you would like to get admitted under another one, that you had got admitted for your previous admission. You go to someone else for physiotherapy. You go to someone else for your ophthalmology needs. You go to someone else for your dentistry needs. So the needs are diverse, but there is no single solution that is available to patients to receive these services from a single vendor today. That's the reference to Book My Show. The third big opportunity is care management solutions for chronic and lifestyle disease management. Now, see, a lot of you would have families at home, kids, and even parents. Tell me about one survey that you heard about, even in the Indian market context, which gives you end-to-end package for covering not the treatment, but the facilitation of treatment part from a healthcare needs perspective. An agency that can remind when you need to do your annual health checkup, the agency that could remind when you're with the immunizations that you, the agency that defines, or lets you know when the checkups are due and for what diseases for your parents, and also facilitates the visits and makes the bookings and all of that. There is no single window service today that does that. That's for more obvious needs. But even for more complex needs like diabetes, hypertension, cardiovascular diseases, what you do not have is a comprehensive care management service that could provide you with an ability to manage your disease well, provide you an ability to continue to work with the physician of your interest, because a lot of services are there today, but they'll bring their own doctor to the team, which you don't want because you have a preference. You're comfortable, working with one particular doctor. He's been treating you well, so you don't want to abandon him. So till there's no service today which allows you to provide this capability in a manner that you can continue to work with or get treated by physicians of your choice. There is no benchmark today for comparing healthcare service quality and cost in India today. More broadly, when you see the same service being offered, you will see different price tags at different healthcare facilities. Classic example is LASIK operations. So there is no benchmark around quality either, and there is no comparison that you get on cost. This is something that's also, this is like cover for a policy bizarre for healthcare. If I want to get an elective surgery done, if there's a way for publishing the quality of these services and giving us a way to compare the cost and the ratings, you would like to go to a particular service that's highly rated and has the best quality. But unfortunately, today you can't do that because it's not available. And there are some regulations that in some capacity stop that from happening. For example, under Indian laws, an Indian physician cannot market his service. Hospitals can, but a physician cannot. But that's another big gap that's available there. The next big gap is around national registries for patients and providers. in most of the developed countries, you have a single registry, one for providers and one for patients. So all the providers who are in the business of providing healthcare services, whether they're hospitals, clinics, labs, physiotherapy centers, imaging centers, all of them are identified by one unique national identifier. And once you have that, you could essentially start rating those services also at some point. Similarly, as a patient, while the book my show example that I was giving, while your needs are diverse, you are a single patient. You should ideally have a single record. And this has not been a case yet in I think in most of the developed countries too. It is still very fragmented. The records are mostly kept in different systems, and there's no single view of what the patient's health history really looks like. The last gap is this is to an extent solved in some countries, which is an integrated network of providers who are also connected. So once we have a registry of all the providers, the solution is to make sure they're connected so that things that are done between these providers today can continue to happen seamlessly. And what are those things that providers do? Ordering a particular medication. Can that prescription directly go to the pharmacies here in India? I'll give you an example of US where e-prescription is, I think, predominantly 80 to 90% used today. And the concept is that when as a physician you're prescribing a drug, as a patient I can choose the pharmacy of my choice, which could be the pharmacy next door, or the pharmacy at my home, near my place. And the prescription is digitally routed to that pharmacy. And I can go and either pick the order from the pharmacy, or in some cases, they could deliver it to my place. If I'm placing investigation orders, lab orders, imaging orders, these orders are also digitally sent to the facility of your choice. So that then you can go there and do the test. If you do the last mile connectivity, you can even send the lab home to pick up the blood draw. So that level of connectivity, which to an extent is available today in some developed countries, is what is required here too. So that one, delivery happens much faster, the number of errors involved in the care are much less. And three, what you could also do, even if it's being covered under insurance, the insurance companies get a lot of insights into, okay, this treatment was prescribed to this patient, but they never turned up. They never got their X-ray done. They never get their USG done. They never picked the medication. So which proves that, they are not complying with the treatment protocol which is being given, which I think eventually it will come into the Indian market too, which will result in your premiums going really high because you're not serious about your treatment.
It'll be a good time for a few questions.
Yeah. So thank you. So,
yeah, I'll cover one last slide just to give some idea about, for those people who want to build softwares and products in healthcare. How does healthcare business really operate? What are the key things that you have to look for? If you're looking for building any solutions for physician offices or outpatient centers, you need to look for what the revenue per patient is for that particular provider. Okay. And you will have physician offices that just do visits, like the MD physicians, internal medicine folks, or you could have ortho physicians or ENTs who could do some procedures too. So before you decide on what to charge and what is the paying capacity of those people, you need to look at what is the average revenue per patient for those cells. If you look about hospitals, it is revenue per bed and what the typical average length of stay is. The lower the length of stay, the more money physicians, the hospital makes. You may have questions, how come if patients stay less number of days, more money is made? That's because doctor-patient ratios and our beds per 1,000 patient ratios are too bad. For example, our current doctor-patient ratio is about one doctor for every 1,800 people. This is data published by NCBI. The minimum limit prescribed by WHO is one doctor per at least 1,000 patients. Where we are at India is one doctor to about 1,800 patients. This is an older data for number of beds. I think there are about 0.7 beds per 1,000 patients. Now you can imagine what this means in current times of COVID-19. If we really let the infection spread, there are not enough hospitals or ICU beds to take care of the patients who will need it. And if you focus on specific specialties, try to focus on high yield specialties like ortho, cardio, dental, plastic surgery, and surgical specialties, because in these specialties the revenue per patient is much higher as compared to an internal medicine specialty.
Thank you, Mohan. We have quite a few questions. I'll go with the first question. What are the disruptions in medical field which may force, due to COVID-19 situation, world for technologists in near future? So I repeat, what are the disruptions in the medical field which will force COVID-19 because of COVID-19 situation for technologists in near future?
See, the first and the biggest disruption is the entities in healthcare who used to compete with each other are now trying to work together. Whether it means that creating, sharing patient data to publish joint dashboards around where the infected patients are and where the highest mortality rates are and what treatments seem to work and which ones are not working. So that is the biggest disruption. In various countries already, big hospitals and chains have tied up together to create joint dashboards and share these treatment protocols more broadly. The same thing in India, I think, is being facilitated by ICMR. So that one is big. The second big one is the visits have totally gone virtual. I think that there is a huge drop in the number of physical visits happening now, and most of the visits have gone virtual, which most of the visits are now happening either on chat, voice, or on video conferencing technology. All providers across the board are experiencing a trend where their virtual visits are much higher than what they used to be. The third trend now is, it's like we are in lockdown, and when we come out of lockdown, there is going to be a process for us to get to our regular rhythms. Similarly, under this lockdown, a lot of these healthcare institutions are facing a lot of challenges. See, I highlighted the specialty difference, right? Who would treat a COVID-19 patient? The kind of specialty that is required to treat a COVID-19 patient would typically be an internal medicine guy, or a chest physician or a respiratory specialist, or it will be an intensivist. But these are not your high yield or high revenue generating specialty. So most of the hospitals are being managed by these people now, which also means that all the high revenue generating procedures, all elective surgeries, plastic surgeries, the knee replacements, or the hip replacements, or the not urgent, the dental treatment that have to happen, all of those have been postponed. People do not want to go to hospital right now and get exposed to an environment where there could potentially be COVID-19 patients. So a lot of these procedures are getting cancelled or postponed, which means a lot of these hospitals are actually running under, private ones, of course, are running with low occupancy, and are running even with low occupancy, generating much lower revenue than what they would expect. So any solutions that can help them get back to the normal world faster would be highly appreciated by these people, because it makes a direct impact on their top lines and bottom lines. So if you could build an AI-enabled solution that automatically goes through the patient records and the cancel schedule, and comes back with an entire end-to-end process of figuring out what are the most critical appointments that we should reschedule the earliest, or maybe based on revenue, send those requests to the patients automatically, send them a link to book an appointment, get those appointments booked, make sure that the appointments and the beds of these hospitals are filled. And any solution that helps them do that more broadly will go a long way in adoption.
Great. And another question is, when you're looking to hire product managers in healthcare companies like yours, what are the selection criteria? Can a functional product manager find a place, or is there any place for technical product managers?
So, see, there are multiple types of product managers. We have product managers for our technology work also. If there's a lot of work that we're doing on the platform side, which is not as much functional from an end user perspective, there are product managers for those teams too. For those teams, for sure, we try to look for product managers who have a lot of technical background. But more broadly, for building solutions, end user facing solutions, a technology background is not a must-have. I think there are pros and cons of having technology background, depending upon how well you handle it. I myself have been a technologist and a Java developer for in my earlier part of the career. So there are advantages and disadvantages of it, but it is not a requirement. Not at least for the teams that are building end-user facing capabilities. What is important though is again, even the functional knowledge. Though it is desirable, it is not a must-have, not because it is not required, just because there is not enough talent in the market in healthcare product management space that can come on board with that kind of functional knowledge. So for most part, the core must-have criteria revolves around core product management and product ownership experience. If you don't have healthcare experience, fine. If you're a great product manager, come on board. We'll train you on what healthcare looks like.
That's amazing. The next question is, how does one set up a user research system with physicians who are very busy and might not have the time to give their point of view on products or time for discovery user research questions? So it's basically around user research with physicians.
Right, I've kind of answered this question in some capacity. So you need to identify a user group that aligns with what you are trying to do. For example, if you take a telemedicine use case, and to a user who is an orthopedist, he's not going to have a lot of interest because they can't do much on telemedicine, maybe except for follow-up. That too, in situations like today. So they need to touch the patient, they need to examine, they need to see, if things are healing well or not, whether the bone is fitting well or not. They need to take X-rays. So it depends on how well do you identify the group of users that you want to engage with. The mantra there is you need to find those people who are aligned with the problem statement that you're trying to solve. Whether it's about using AI to predict cancer better, or whether it is about detecting diabetes early on. So you need to really, identify the focus group based on their level of interest in what you're trying to achieve. And, after the call, of course, I'll share a list of avenues that you can explore to do this, to make this happen. But that is the only thing that I've found in my 16 years of working with physicians and providers. That has got us always an opportunity to sit next to them, observe what they're doing, and get quality feedback from
them. The next question is about different clients have different requirements or features from any product they are going to use. So how does how do you set these requirements? I understand the question right. So
it's a tricky question. See, it essentially is what product management is all about, right? Whether you're building a product, you're building a custom solution for somebody, and just so you will probably lose some opportunities because you decided not to build something that looked like an offshoot, not really aligned with what you wanted to do as a roadmap. And that's why that early part of doing the research right, getting it content tested, and informing your backlog is important, because then you know what you need to focus on. Now, as a startup, you may have business and revenue priorities, because of which you may decide to take up requirements and do something custom for providers. But that's a decision that you take. That's not a product informed decision. That's a business informed decision that you would like to do, to maybe continue to generate revenue. And there's no simple answer to this question. It is what product management is, which is you need to figure out whether what is being asked, is it aligned with your roadmap. What kind of leverage does building that feature give you? Do you believe what you're trying to build is specific to only a single customer and doesn't broadly resonate with other customers? Now, one way of doing this, if you already have a captive base of customers that you're going to work with, is you should have an idea board shared with these customers, so that the users at these customers can essentially vote for different capabilities, which is another input, diverse input that you get from your captive user base around what most of them feel about your roadmap or any other feature requirement suggestions that coming in from other customers. So we have called as voice of customer. Many companies do. The whole functioning of that is they collect user inputs that are being reported by individual clients, and they try to predominantly publish it and get more broader feedback from other customers too before they decide on investing in it. That's another way in which we solve that.
Couple of questions more, Mohan, before we close.
Yeah.
Mostly the role of product managers in India are inbound or tactical, but the expectation from the employers are more towards outbound or strategic role. How can we move towards this?
I don't think I agree with the person who's asking the question more broadly. I mean, it definitely is the scenario where it's more internal focus, but for very specific companies that have captive center here and their end users don't really are in India. But there are many classical examples where even if the user base is not in India, where the product managers here are on the front line of product development, defining strategy and building products. Me and my team are a classic example. Our mobility product is being developed entirely from the Pune office, but we are in control of the end-to-end ownership of that product, what to build, what not to build, when to release, when not to release. Engaging with those users, frequent travels to meet these users and keep a pulse check on them. So as there are examples of captive centers that use product managers here predominantly for internal focus stuff, I think there are a ton of examples also there where product managers are actually working with end users and have an end-to-end control of their product roadmap and the strategy. And again, I think what doesn't give you any excuse, irrespective of which of these areas you're really working on, is to keep improving your product management skills in the areas that one needs to. Always look for avenues where even if it's a captive center and you don't get much exposure, is there a way to engage with those people who are on the front line? Is there a way to engage with those people who are defining the strategy? So that even if you're not doing it directly, you are plugged in, why it is being done, what is the logic behind it, and how people are taking decisions, so that it doesn't become an alien concept to you. And again, the other biggest thing to always remember as a professional is, you are responsible for building your career. No company is equipped with that task. So if you limit your professional capabilities to what is being offered to you at the company, you will be missing out on a lot.
Great insight. As last question, what are the avenues in product development for CRO or regulatory compliance?
I think my deck does highlight that, in an extensive way early on. See, after the fact that what you do kills the patient, the next biggest thing that happens in healthcare is regulatory compliance and patient safety. So anything and everything that we build is looked at from the lens of regulatory and compliance requirements and rules and security, and also from a patient safety perspective. If what we are building and how we are building it does, pose any threat to patients. So these two areas, there are extensive requirements for researchers. There are extensive requirements for people who understand these compliances, who are functional experts in these compliances. Or are subject matters from the healthcare industry itself, or physicians. There's a lot of people who are physicians on a broader team, who do demos to end users, who are even active physicians today, but continue to talk to our customers about how to use the product better, how to use it well. There are a lot of physicians who do patient safety validations in terms of, certifying that yes, what you're building is safe for patients, there's no risk there. So the opportunities are ample because compliance is core and central to whatever is done in healthcare.
Thank you, Mohan. I will now close this session.